Hey everybody, Ryan here, emergency medicine pharmacist and clinical toxicologist. This is the second video in a series about NSAIDs and their impact on COVID-19. If you want to know how NSAIDs specifically might affect COVID-19, go to the first video, The Truth About Ibuprofen and Coronavirus Explained. This video is going to look at NSAIDs overall and how they impact infection, and is based on what we've already known about NSAIDs this entire time. So we'll take a deeper dive into how their mechanism can impact our body's ability to fight infection and what kinds of adverse effects we might see. If I missed something you wanted to hear more about, or if you have questions, comments, ideas, leave a message in the comments below or reach out to me on Twitter at empoisonpharmd. NSAIDs still carry all the same risks that they had before. It's just that COVID-19 is not the reason why they might have harms. So we know that NSAIDs block cyclooxygenase. And if you block cyclooxygenase 2, you actually increase this molecule arachidonic acid to get shunted down this pathway on the right and lead to more thromboxane production and platelet activation. And this is why all NSAIDs, every single one, has a black box warning about increasing the risk of thrombosis while you're taking NSAIDs, the risk of blood clots. So there is good data to support that your risk of stroke and your risk of myocardial infarction are increased when using NSAIDs while you have an acute respiratory infection. And that holds true even if you just have an acute respiratory infection, that increases your risk, as well as if you're just using NSAIDs alone, that increases your risk. And if you have an upper respiratory infection and you're using NSAIDs, the risk is compounded. So that certainly is something that we should take into fact. Additionally, if we block cyclooxygenase, it shunts arachidonic acid down the lipooxygenase pathway. This can make a molecule called leukotriene, which is very good at recruiting white blood cells, and that can have complications too. In fact, we try to reduce leukotriene in asthma patients in order to reduce the likelihood that they'll have an asthma attack, so we can turn off their inflammation. And there is data to support that your risk of asthma exacerbation increases if you're using NSAIDs, and that, at least in some case control studies, children who use NSAIDs for upper respiratory infections were more likely to develop empyema, which is a ball of pus from white blood cells in their lung, compared to children who did not use NSAIDs. It should be noted that many of these studies suffer from confounding, where they're not doing a randomized trial to see if NSAIDs cause empyema, they're just looking back at patients with empyema and seeing if they took NSAIDs. So we don't actually know if NSAIDs caused the empyema or if they just had more severe disease, so needed to take NSAIDs to treat their symptoms and then wound up with empyema from the severe disease. Finally, we have the side effects that really have nothing to do with infection but have always been there, and that's if we stop production of prostaglandin, we don't make as much mucus in our stomach, and that can give us gastrointestinal bleeds or stomach bleeds and peptic ulcers or stomach ulcers. And we aren't as well able to regulate the blood flow to our kidney, and that can cause kidney injury. So with all these side effects, is there any real reason to choose ibuprofen over acetaminophen? And at least in one study of almost 900 patients with upper respiratory infections, there's really no difference in degree of symptom reduction between Tylenol or ibuprofen. So the takeaway? There are a lot of nasty side effects with NSAIDs, but it's nothing new. COVID-19 and ACE2 upregulation, there's really not enough information for us to make one conclusion or another about the impacts of NSAID on disease. We need more clinical outcome data. Patients who are taking NSAIDs long-term should not be stopping them without talking to their doctor. Stopping aspirin for cardiovascular event prevention could be very dangerous, and those who need NSAIDs for gout or osteoarthritis should likely continue taking them. And if we need NSAIDs to prevent fever or treat pain, it's probably okay as long as we know their risk profile. So patients who are low risk for the adverse effects that we talked about can use it as a first line. And those who are unable to tolerate acetaminophen or need breakthrough from acetaminophen for breakthrough pain or fever should consider ibuprofen a reasonable option. Those who are higher risk for adverse effects like advanced age, history of blood clots or bleeding, or history of gastric ulcer disease, asthma, or renal disease might want to avoid taking NSAIDs. Tylenol or acetaminophen has its own bag of problems too, but generally, if taken at the FDA-approved doses, is able to avoid any significant toxicities. So, I know we went through quite a lot of information. Hopefully this was helpful for you. If you have any questions or concerns, leave them in the comments or tweet at empoisonfarmd, and happy to address anything that I can. Thanks for listening. Hey, little update here, guys. Apparently, I can't list all the references on the YouTube description because there's too many words. So I'm listing the reference slides here. Feel free to pause the video and look through. They're listed alphabetically. So if you do want to take any of the references, they're all listed here for you. All right, thanks for watching.